The International Association of Oral and Maxillofacial Surgeons is pleased to welcome you to today's webinar, 3D Virtual Planning and Computer-Assisted Orthognathic Surgery. My name is Sandy, and it's my pleasure to be the facilitator for today's event. I'd like to formally welcome the participants who are joining us today. Please note that today's call is being recorded, and all participant lines will be muted during this broadcast. If you experience technical difficulties with the web portion of today's program, please email IAOMS@compartners.com or send a message in the chat box. If you are listening to the program over the phone and you need assistance at any time, please press *0 and an operator will assist you. This presentation will last up to 60 minutes and will include question and answer opportunities at the end. You may submit a question at any time by typing into the chat box at the lower left corner of your screen and clicking on the send button. I'd like to direct your attention to the links box located to the left of the screen where a webinar evaluation is located. Simply click on the link at the end of the presentation and a separate window will open. Your feedback is very important to us. It's now my pleasure to turn the webinar over to Dr. Mike Markowitz, who will introduce today's speaker.
Thank you, and welcome to the IAOMS community throughout the world. My name is Mike Markowitz. I'm joining you from the United States, and I am the moderator for the session today, entitled 3D Virtual Planning and Computer-Assisted Orthognathic Surgery. It's my pleasure to be here with you. As Sandy mentioned, we will address your questions during the last 10 minutes of the program, and again, so please queue those up for a speaker as you listen in. At the end of the webinar, we will send you a brief evaluation, and we'd really appreciate your input as we continue to develop the programming to meet your needs. Now I'd like to introduce our speaker, Dr. Majeed Rana. Our speaker today talks about a very important topic. Dr. Rana serves as the Vice Director of Craniomaxillofacial Surgery at the Henrik Heine University in Düsseldorf, Germany. Now I'll turn it over to Dr. Rana.
Yes, Mike, thank you very much. And the organizers, dear participant, it's an honor for me to use here the platform of the International Association of Oral and Maxillofacial Surgeons to give you an overview of an important topic of virtual surgical planning in orthognatics and the use of patient-specific implants for splint-less orthognatic. The content what I'll going to present you in the next 45 minutes is, first of all, I would like to introduce you to virtual planning, especially where we use virtual planning in orthognatic surgical procedures. Then I will demonstrate you something which is a little bit controversial in orthognatic surgery, the topic about splint-less surgery and where we work with it and where we have now done our research and developed new patient-specific implants. And finally, after 45 minutes, I will conclude after presenting some clinical cases to you. So when I started my career, and I wanted to get educated in orthognatic surgery, then the conventional planning in orthognatic surgery was always in the hand of the oldest senior consultant, you know, like the druid who was making his soup. And he was kind enough to teach you that at the end he gave his secret to you. And the secret of this old read or this old senior consultant was kept like the formula of Coca-Cola, which is in Atlanta. So this is the background a little bit about that. And I was pleased to be educated by several druids, like my senior consultant, Dr. Brachvogel. You can see him at above on the left side. He was my senior who educated me 10 years in orthognatic surgery, especially in conventional orthognatic surgery. Unfortunately, he died. Then my former boss, Niels Claudius Gellrich, half a year spent with Bert Hammer, who educated and showed me a lot. My last vice director, Alexander Schramm, Wolfgang Carter, where I spent time with him 2 years at Alice and Gwen Svennen, who really both of them influenced me in the procedure of orthognatic surgery. So But what was actually the basic thing, what I learned out of them? And what I learned is you can only treat if you're able to analyze. And there the idea of 3D analyzing came. And very important is, and this is what I really hated in conventional planning and orthognathic surgery, that every surgeon, like you can see on the left side here, was using his own equipment. And there should be something like this, like idea from IKEA. That's a Swedish company who make the things very simple, and you have instructions, and you can just follow the instructions, and at the end, everything will fit. So, finally, what's the major difference? And the major difference is what we see depends mainly on what we look for. That means, translated, that we can only treat what we see. And there it starts. The 3D planning can only be 3D if we have the data set of the patient available. So nowadays, if we talk on orthognathic surgery, then we need to look about challenges what we have in our preoperative planning, like we need to coordinate with the orthodontics, like if how is the therapy with them, do we need decompensation therapy, or we do something like surgery first, which is more and more common in European countries, and more we are doing surgeries for this. We need to consider about the different locations where we want to do the osteotomy. For example, if you want to bring the maxilla forward and it is very hypoplastic, we can perform a high for one, and if it is a transverse problem, we can consider a two-piece maxilla, and we need to control of potential relapses, because we will see them, and definitely there are relapses we need to consider and see. There is something about the condyle. It's an important thing what unfortunately many surgeons don't think about, but it's important, and we need to think about the condyle position. And we have something like model surgery, which, as you know, nowadays can already be done using computer and different type of softwares. The general planning aspects, functionally, definitely, this is what we want to achieve, but we want to idealize the occlusion. We want to control potential relapses. And the other thing which is very important is the aesthetical aspects, like the contour. We need to think a little bit about the prominence of the chin. This is where we want to do a clockwise and anti-clockwise rotation, and our dental and facial midline. And this is what we need to think about from the profile, especially if we watch to the philtrum, because 2 to 3 millimeters is what we can surgically correct, but everything else need to consider during our planning procedures. And the biggest thing is every technology is not helpful if it does not help you to reduce complications. If you are using a technology which increase complications, then no need to use it. So definitely a technology should be there to help us to get to our way as simple as possible and to reduce complications as much as possible. The next thing is a little bit I want to focus, and is about the nomination of about what are we talking about, and if we want to talk on with the orthodontics and with our colleagues, we need to consider that we are talking on different type of views. We need to tell them about where is the problem coming on, from which type it's going on. This is like you can see here, or patient with a maxillary deficiency, and if we have a maxillary deficiency, we can always have a mandibular deficiencies. We talk on vertical maxillary axis. This is actually the easiest part to solve, where you do impaction. And we have something like maxillary deficiency and mandibular axis. And especially if we think or talk on the maxilla, where we want to maxillary descended a little bit, we need to think about to use some bone graft like iliac graft or graft from the mandible. So the planning tools in orthognathic surgery, doesn't matter which kind of planning you're using, if you're using conventional planning or you are using computer-assisted surgery, always we need to think about to first solve the transversal discrepancies. We have problems with crossbite, and always it's better to do it in the first operation, doing a surgically assisted rapid maxillary expansion to avoid sometimes the level 1 osteotomy in 2 segments. Sometimes it's necessary, but it's better to perform and to solve the transversal problem first. We need to consider asymmetries, especially in cases where we have facial scoliosis, and they need to be considered differently. And we have patient with cleft lip palate, and we need to think about the rear cases, which are mainly class 3 and combined with a micrognathia of the maxilla. This is a book by Gwen Swennen, and this is what I want to recommend, especially if you want to start doing virtual treatment planning of orthognathic surgery. And again, if you can see the challenges in preoperative planning, doesn't matter if you plan conventionally or via virtual surgical planning, our targets and challenges remain the same. So these are the typical steps in planning, what we want to use and what we want to do. First of all, we define an ideal occlusion. The easiest way to define ideal occlusion is taking the 2 fluster models, the upper and the lower jaw, putting them together and define that this is the occlusion. The second one is to ideally consider the profile, and there is the position of the upper incisor. This is very important. How many millimeters you want to show it, and this is what we already learned from William Arnett, that the position of the upper incisor is very important to define the ideal facial profile. And we need to define the ideal chin position. With the chin position, we do the sacral rotation clockwise or anti-clockwise, where we see that the chin prominency is there or not. And we need to consider overcorrections, because we will have relapses. Everybody will have relapses, and that is important to consider. Sometimes they are less and sometimes they are bigger. So this is actually our workflow, where we perform model surgery only in few cases, only in single jaw surgery. So the combination of virtual surgical planning is actually our workhorse, where we do that. A full digital planning, that means with an intraoral scanner, with a virtual occlusion setup and things like that. In my opinion, there is no proper software available at time which gives you everything in one solution. It can work maybe in research sectors, but in a daily clinical routine, a full digital planning is not available. And there is something like a Splint-less planning, and maybe this one can be the next generation. If we talk on the positioning of the maxilla, then we need to think about that to position the maxilla means that you can only adjust the maxilla according to the skull base. Otherwise, if you watch to an airplane and it's trying to land, for example, to Chicago, then exactly the airplane needs to consider different type of movements like roll, yaw, and pitch. And actually, the maxilla, exactly the same movements it's make if you consider that according to the skull base. We need to check about the translation, which can be lateral, vertical, longitudinal. This is where we can move the maxilla. We have the pitch, and with the pitch we consider the ento and retro inclination. With that, even the chin positioning, because the mandible is following. We need to check about the roll. This is our occlusion plane, where we again can play a little bit with the chin positioning, where we can see if maybe 1 degree posterior impaction can sometimes help you to verticalize your patient. And we have the yaw, where we have a vertical rotation, especially if we watch on the canine, which is sometimes, if you have a long laugh line, it's sometimes very important to show you the prominency of the canines. So, as you can see, the maxilla should be positioned according to the skull base, and not like the conventional planning, supported with a movable mandible. If you fit the maxilla with a movable mandible part, always there is a shift which you cannot consider and recognize. You always do some controversy or some compromises during the operation. That's why the idea came to position the maxilla according to skull base without adjustment to the mandible, because anyway the mandible will follow. And for the planning of the position of the maxilla, this is what I already mentioned, that the most important part to position the maxilla is the position of the upper central incisors, and that we need to consider during our planning. The other thing what we see is the mandibular positioning. How often we realize that we have done a conventional planning, and if we move the mandible, then we realize, oh, exactly here, that there is an overlap of the dental part of the mandible body and the ramus ascendus. And then you need to do a lingual osteotomy. And to avoid that, virtual planning is sometimes very important, where you can play around and see. Maybe you can do an alternative movement of the maxilla, like a rotation of the maxilla and then a slightly shift to the left side to see if if the mandible follow, then you can see that maybe the interference here disappears. Another option what I want to show you, and this is what I regularly do, if I have patient to do Bimax surgery, especially at that patient where I only want to correct the midline on the mandible. If I don't want to use and do a long advancement of the mandible, I use the Peters-Schlossmann technique or the supraforamina procedure. The advantage of that is that you can now easily move the mandible and are always aware of the nerve. Disadvantage is if you need to advance the mandible a lot, then you have limited contact to the bone. That's why this is a nice technique to consider and see. And here you can again see on the left side how nicely here you can perform this kind of surgery, and the access to the mandible is minimal invasive. The thing where we started to do virtual surgical planning was using something like a guide support. We wanted to fixate the ramus. Like, as I told you, we can now move the maxilla according to the skull base with technology, with virtual surgical planning. But what about the mandible? So there the idea started with a splint-less surgery, and like you can see here that we have a guide, and with a guide there are now a drilling guide and a cutting guide, and with a cutting guide we can now easily perform prior to the osteotomy already the pre-drilling. We can pre-bend our plates like you can see here according to the model, and now we started to fixate that. So this was one of the first cases, and I want to show you these like views from the operation room. You can see this was the guide, and this is the initial splint, and with the initial splint you can see we already have inserted a drilling guide and a cutting guide, and now we could use the piezo saw, and with the piezo saw we did the osteotomy and pre-drill all the positions. And here on the left side you can see here are the plates. They were pre-bended before, and here a CAD-CAM splint for the final occlusion is there, and now we could easily use these pre-bended plates, and intraoperatively it fits nicely and was very time consuming. Like on the computer, everything is easy. Now I want to show you some cases, and this was one of the first cases, and like you can see here from the profile, it's a case of a class 3, dentally almost decompensated, a little bit less at the mandible, but this is where you do almost what you discuss with the orthodontic. And the idea was now to perform a high-low for one osteotomy, septorhinoplasty on the same step, and bring the maxilla forward and to adjust a little bit the midline, what you can see here. And I performed the Pertus-Schlossmann procedure and using the Rana fixation guide. This is how it looks like: CAD-CAM splint, initial splint, and final splint. And the initial splint, you can see here, was with the cutting guide and with the drilling guide into it, and pre-bended the plates onto it. And here you can see the view, like here was the cutting guide. Now you could easily adjust that. And here the pre-bended plates for the maxilla and the pre-bended plates for the mandible. And like you can see here and here easily, exactly where it was planned, here and there are the two screws, and exactly there the plate fits nicely, and we could perform the surgery. And that was the occlusion directly after surgery. And here if you see preoperative and postoperative bimaxillary surgery, a septorhinoplasty, and advancement of the maxilla in a high level 1, preoperatively and postoperatively. We performed this kind of surgery and simulated the cases, and we realized that after 10 cases there was still something which was not very accurate, and the maximum what we found out was a deviation of 2.7. And the idea was if we can do and be more precise. And we realized that the problem maybe is that the guides are made out of acrylic or polyamide, and maybe this is not solid enough to perform. So then the idea of a CAD-CAM splint came. That means a splint, what we are producing via additive manufacturing, but we wanted to position the maxilla without any splint. And we performed the surgery. The first time we performed the surgery, 2013, and I'm presenting you the first case. And it's always like, if you want to use a new technology, it comes to always to the difficult cases. We never learn to perform maybe easy cases, because then if you have an easy case, you don't need such kind of technology. And this one was definitely not an easy case, like you can see here. It's a left convex facial scoliosis, and we have a candilar hyperplasia on that side, you can see here. And the idea was now to simulate and bring the maxilla forward. And in blue one, this is the patient-specific implant. And the patient-specific implant, all the movements, all the positions of the maxilla is inside. And this implant was selective laser melted. It's a titanium alloy. And then it was looking like this. Very bulky at that time, a little bit, similar to gladiator helmet. But at that time it was not we didn't have other possibilities, because it was cutting, drilling guide, and positioning guide, everything in one. Here you can see that was the acrylic or polyamide cutting guide, where we positioned the litho 1, and the pre-drilling was everything in the other guide. That's why it was bulky. And here for the mandible, we use the Ramos fixation and a CAD-CAM splint. And this is the situation during the operation. And again, you can see we use the help of navigation. Here, the navigation. And we wanted to double check if the planning what we are using and the movements what we are using three-dimensionally, if they are correct or not, because this guide always gives us the information at the frontal and the lateral part, not at the posterior part. That's why we use the navigation. But when we realize after using that, definitely if we fix everything here at the front, and all the positions what we have pre-marked exactly fit to each other with 20 screws in different direction, then always posterior it fits. Only thing you need to think about, but this is, you need to think always if you perform orthognathic surgery, that you have done enough impaction of the posterior part. So after doing that, you can see that was the final splint situation. Everything is there on that place, and now the condyle is getting out. That was it, and the gap was filled with temporal fascia. So that was the postoperative result, and we superimposed the planning with the postoperative result, and we could see that the planning perfectly fits to the postoperative result. So that was the patient. You can see clinically on the left side that was a facial scoliosis, and after the operation the patient is totally straight, and only now he received the half a year later we did a plate removal because this plate was very bulky and we wanted to remove it. Again, left side preoperative and right side postoperative. Again, the idea was running more and more, and we wanted to have now splints or let's say totally the bimaxillary surgery without splints. So maxilla we had done, and now we wanted to solve that for the mandible also. That now you can see here we have a patient with a frontal open bite and a massive vertical axis, and the idea was now to impact like 8 millimeters. And there you can see this was the idea behind it. We wanted to do impaction of the maxilla. Everything what you can see here in red was to be removed because this is what we want to plane. And now you can see this device. With this device, we want to fixate the ramus of the mandible, that it's not movable. And all the movements are now planned with preoperatively planned drilling and cutting guides. And here's the position of the plates. And even now, we wanted to have every plate patient specific. So again, this is the plan. And now you can see they are much, much thinner and much, much nicer. And because of we don't want to dissect too much soft tissue, that's why we gave them such a Mickey Mouse design. And here you can see the plates now all around are there. And we just did some marking here, 1 millimeter marking, to see if the advancement of, like here we planned like 2 millimeters, if we exactly visualize that in our patient-specific implant. And the other advantage what we have through this technology is that we could now preoperatively simulate the virtual screw positioning. So you can see we have many, many advantages, and with advantages we have even some disadvantages, and the disadvantages we need to put the patient on CT or on a cone beam CT. So that means there are some radiation. But if we think about how much radiation we sometimes put for patient just to insert dental implant into it, and now here we are changing the proper bites and the facial profile and everything like that. I think in that cases it can be considered. And the other disadvantage is you need the companies who provide these kind of devices to you. They don't give it for free, so they sell it for money, which really needs to be paid, and if not by the patient, you need to pay it by yourself, by your budget. And in a university setup, it sometimes can work, but not very often in a private section. So again, we did the preoperatively simulation. Like here, you can see the LIFO 1, and here the mandible split to perform the BSSO, and this is the situation intraoperatively. Like here, you can see this is the ramus fixation exactly to the guide. Here you can see the position, it's exactly fitted to the guide. So before we did the osteotomy, we marked all the position of the screws, and we marked all the positions where we want to perform our cutting. And for the cutting, it's nice to use the piezo saw, but you can even use a bore up to your choice. And now you can see exactly how fine it fits after the positioning, and here you can see the final result, and here the patient-specific implant for the maxilla and the patient-specific implant for the mandible for that situation. After 6 months, we did a plate removal, and you can see it nicely consider and bone is everywhere there, but sometimes your assistant get off with the Langenbeck and open the sinus, but that is easily to solve. But otherwise you can see nice result, and the screws are out and everything was healed nicely. The problem was, what we had was now to measure and to see that what we have planned, if it is really exactly there where we want to go. And the idea came that we need to perform Atlas heat map analysis. What does it Atlas-based heat map analysis means? That means before we perform the surgery, we do a planning. So with a cone beam CT or a CT, and we have our STL file where we perform the LIFO 1 osteotomy. This STL file is now we made a postoperative cone beam CT or a CT, and exactly we see Atlas-based to avoid scatters by the braces and by the wire. This Atlas fits exactly to the LIFO 1, and this is how this Atlas-based heat map analysis can make. So preoperative position of the maxilla and the postoperative position of the maxilla. And so you can see that we are below 1 millimeter with this new procedure. And that was exactly with that patient. You can see preoperatively open bite, and postoperatively directly the occlusion is nice. And here left side preoperatively and right postoperatively. Again, our journey went on, and we wanted to do something where we even wanted to be as close with the conventional plates. And this was a young girl, you can see, still not orthodontically treated, need to get the decompensation therapy, and sometimes in cases like this we perform even surgery first, and later on the orthodontics can start doing the decompensation therapy, but again you need to check with the orthodontics. And the idea was the same. Now cutting guides, drilling guides, and now you can see with the cross, these are the areas after position of the maxilla we want to remove, because I don't want to have bulky metal into the maxilla, And that was the idea behind that. We wanted to remove this kind of pillars. And you can see, again, we needed the final splint. In that cases, we didn't use the patient-specific implant for the mandible. And here you can see that there was a cutting guide. We use acrylic one because of the lower movements. But more now, I don't use these acrylic anymore. I use everything now on titanium, even the cutting and the drilling guide, because of it's much more precise, and I will show you in few slides our results, which gives you the difference. And after positioning of the maxilla, you can see now here easily you could remove the pillars, and the bone is exactly there where you have planned it prior to surgery. And then we analyze it. You can see here that the transparency almost exact, and that was the situation directly postoperatively. You can see even the garn is still there, and here when we do the overlap, then you can see that exactly to the planning, three-dimensionally, the positioning of the jaws is there where we have simulated with a computer pre and postoperatively. Again, the same analyzing system, and you can see even in that cases we are below than 1 millimeter, and that's preoperatively. And again, swelling is there remaining directly after surgery, pre to post-op. Another case where we perform this kind of surgery, just now want to jump off to show that you can use it in different types. You can use it in two-piece maxilla. You can use it in mandible first cases and can optimize these kind of techniques. And finally, we did a analysis of 11 patients, and we see that the intercondylar distance simulation was close to 1.4 millimeter. That means that we are almost very, very close to the positioning of the intercondylar mandible. And you can see that in that 11 cases for the maxilla, we had a result of the worst result what we have was 1.5 millimeter. That means doesn't matter who operates. At the end, it comes totally on the maximum of 1.5 millimeter. We did an analysis even between the patient-specific implants and the use of CAD/CAM splints, and we have recently published both papers at the European Journal of Craniomaxillofacial Surgery, and we could see that using patient-specific implants, we are very, very close to accuracy of 1 millimeter. And this is what I wanted to show you, that with this technique, you can perform it in all different ways. You can perform mandible first and can later do the maxilla and plan it in all ways. And here you can see the design of the Mickey Mouse implants. I call them Mickey Mouse implants. Maybe some guys of you have a better name of this for me. And here you can pre-drill the position of the mandible, bring the plates into it, do the cutting, and then exactly later on you position the maxilla, and that is the patient pre to post-operatively. Another recent case, only to show that nowadays the resident can do these kind of surgeries, because all the plannings are done with me, and I approve all the things, because only that guy who is able to plan should use these kind of technologies, because these technologies only an add-on. You can. It's not like they will not do the surgery for you. It's only a help. And nowadays, the maxilla in our department, we always use patient-specific implants. And for the mandible, only in few selected severe cases or asymmetric cases, because the biggest advantage, what we realize, is using it for the maxilla. And now you can see that the case of my resident who showed me the picture, and here very easily did the lift for one, bring the plates on, bring the plate back, exactly on that position, and it's like the IKEA principle, and everything is very, very easy. And these are now pictures from our latest publication in European Journal of Craniomaxillofacial Surgery, and this is the latest design. You see, here they are the Mickey Mouse guides, and with the Mickey Mouse guides here, you can pre-drill all the holes. And here with the arrow here, you can realize that this is the amount of bone you need to remove or you need to impact. And here can easily be done and can be removed. And then after the level 1 osteotomy, after you remove the bone, it nicely fits to each other. And I never ever have seen such a precision in other areas in orthognathic surgery via using patient-specific implants. And again, we analyze and we've done the work with Alexander Schramm together in Ulm, and here you can see that we marked landmarks, and we wanted to operate 22 patients for the maxilla only, using these guides, the latest guides what we have, and wanted to analyze where we are. And here you can see where our deviation is. And the biggest, and this is what really surprised me, was that the biggest deviation what we have was on the sagittal point of view, because of if we move with the Tessier hook the maxilla forward, then we had a little bit more difference. But if you look on the small numbers, like we are very, very close below than 1 millimeter. And always, if you can consider every teeth, in every position, always the sagittal position was a little bit more, and maybe the answer of us was because we were all trained to push the maxilla a little bit forward, remove all the bony parts and everything like that, and leave it on the vessel. And sometimes with the screwing there is a little bit more difference, but all the others are very close to the planning. And exactly here you can see the sign values. And here I wanted to show you again the latest publication via Alexander Schramm and me, clinical accuracy of waveless maxillary positioning using customized surgical guides. And if you want to read that more, you can see the data. So actually, finally, what we find out was that using this kind of technology with the CAD/CAM splints, like we were between 2.7 and 1.5 millimeters, and with our latest publication even are very close to 1 millimeter. And I wanted to show you a little bit more a recent case, what we operated last week. And that was a case of a hemifacial microsomia. And we can see again, it's a left-sided, left convex facial scoliosis, but the bite is already normal, and if you touch the skin of that patient, it's like radiated. It's not only a bony, it's even a soft tissue problem. And what we did is here, that was the OPT and the FRS, again, the planning. And you can see the idea was now to correct and position the maxilla, because it was less than 3 millimeter. I didn't augmented that with bone, and otherwise I would use bone grafts. And here you can see the cutting guides, and now totally out of metal. We don't use any kind of acrylic guides anymore, because the titanium ones are much preciser. And here you can see the positioning of the maxilla, and here the mandible split, and here the pre-bended plates on it. And that situation, you can see that here in between the pillars were removed, everything is out, and now I need to show you the postoperative picture, and that was directly postoperatively. Now I have only 1 minute left, and I'm almost done in my time, and I wanted to conclude my lecture and wanted to consider something. it's important if we plan to see and make orthognathic surgery that we need to consider functional and aesthetical aspects. Very important. We need to minimize the risk like nerve preservation, because with this technology we can visualize the mandible nerve. We can see if how far it is from the compactor and can modulate a little bit. In Germany we have the DRG system, and we need to think about that we maybe can get some reimbursement. And what's easy in computer does not automatically means that this is as easy in the surgery. So we should not overstress virtual possibility. And we should keep in mind, and this is important, what is our intention? Our intention was the functionally and aesthetically outcome, and at the end the occlusion should fit where we have adjusted that. And in our center we don't do any financial compromises in asymmetric and cleft patient, doesn't matter what it costs. In a university setup you can afford that. We perform these kind of implants in that patient. And everybody have a dream, and I have a dream also, that one time I can operate one of my favorite football players, and this is just a simulation what I wanted to show you. And I thank you very much for your kind attention. I hope you can have a look onto it and could see and look a little bit controversial on that new technology. And if you have some questions and you want to write me, you can just write me via email. This is rana@hhu.de. Thank you very much.
Well, thanks, Dr. Rana, for the great presentation. I think now we'll take some questions from the audience. And as a reminder, just enter your question through the web in the web conference system, and simply type your question in the chat box in the lower left, and then we'll try to get to them. So the first question, Dr. Rana, comes ask you if all your computer work is done by yourself, or if you have a technician in your department. Yeah. And also, I guess the secondary follow-up is that do we as maxillofacial surgeons need additional training for computer planning and 3D printing in our training programs?
Yes. So very good question. So the first thing is, yes, because we develop these things, we have our own engineers sitting in our department and work to that. But even if not, that you have the possibilities via companies to do it via web session. But I would say it's always better to have your own technician, to your own engineer, if you have the load of that much of patient. If you're performing these kind of surgeries, like let's say 10 in a year, then you should better don't invest the money to have engineers, because you need a proper infrastructure. You need the software, you need the scanner and everything like that. Then it's much easier to do some web conferences. And I'm 100% with you that with time is coming, and now it should be implemented that the virtual surgical planning, you cannot avoid that in oral maxillofacial surgery. There is not a single field in oral maxillofacial surgery where virtual surgical planning cannot help the surgeon. So that's why with me you always find somebody who will promote that there should be an educational program for computer-assisted surgery, that the residents already very early start to learn using these kind of technologies.
Great. And then I guess as a follow-up to that question, Dr. Rana, you know, here in the U.S. at least, we have a set cost that usually most centers pay a third party to do each case. Can you give an estimate on how much it would be as a startup if you want to bring this to your department?
Yeah. So at least what you need is a proper software, and normally there are companies who gives you even the software. Like KLS Martin, for example, they give you software and say, we give you software for free, but that means you need to pay €2,000 per case. but including that case, you will get the implant. So this is a nice model, and it helps you provide that. Then there are companies like Deposintis, and they perform with a true match orthognathic. You could see that I've shown that cases also, and they have several options also that they will say, if you do the planning by yourself, that means then we can do it for 2,000, and if you want us to plan, then we do it for 4,000. But I think for educational purposes, it's important to have the software directly in front of you, at least the planning, because otherwise you will not understand. And it means that the normal software like Dolphin or other things, doesn't matter which one you use, needs investment of between 10 to 15,000.
Okay, thank you. Our next question asks, how do you orient your patient in the 3D environment? So how do you line them up in your preoperative process so they have the appropriate yaw, cant, and the midlines appropriate?
What I do is we do normally a cone beam CT scanning, and I ask the patient to swallow hard and to sit on the relaxed positioning. And how you can and you could always see that the patient get a pre-op splint or a wax bite sometimes if it's not a class 2. In a class 2, I always print or let my technician make a preoperative splint, to have it in a lateral condyle positioning. And before they do the scanning, they should swallow hard and that they are relaxed, and then I let them bite at the situational weaver or splint, and then we do the scanning. Totally relaxed, and then with the software I can adjust the natural head positioning. About where with a soft tissue Hounsfield units, with the computer I can turn the head, I can move the ears a little bit, and it's a combination between clinical view and computer adjustment.
Okay. So we have another excellent question, and that have you tried to superimpose your pre-op and post-op position of the condyle to see the accuracy of condyle positioning? And
this is where my data, what I show you, this is what we've done, and we have 1.4 millimeter. We were too much laterally in average. So the positioning of the condyle is almost well, but always a little bit, like in average 1.4 millimeter, we come up a little bit lateral, but this is clinically not relevant.
I understand.
The condyle stays exactly there where we planned it. Yes.
Oh, okay, wonderful. And then, how do you set your post-op or how do you set your occlusion? In that, I know you talked about it a little bit. Here, a lot of the third-party companies will use, I think, what you talked about with heat mapping and not having to actually send them the splint and the bite. Do you actually register that using
very simple? I use my occlusion very simple. I take 2 fluster models and put them together where I think clinically it fits, and then I scan the models, and this is where I define my occlusion, and then everything will run via computer. I've tried several other things. I've used from the Rana, the occlusionome, to virtually produce occlusion, and believe me, in a clinical routine, it doesn't work. The best thing is haptically take 2 fluster models in the hand, put them together, adjust your occlusion, and then scan the models.
Yeah, I think a lot would agree with that. And then, so do you later scan the models, Dr. Rana, as a follow-up, or do you CT
Yes, we scan. Actually, you only need to scan the outer surface of the models, because the fluster models preoperatively, single jaw, you have it. And the occlusion, the computer will calculate, but you need the surfaces from vestibular. And that's why you adjust once the 2 models with the hand and bring it in occlusion. This is the best way.
Okay. And then you mentioned Dr. Rana, so another question would be, you mentioned hardware removal after you place your hardware, because obviously in the one custom hardware that you develop, it is slightly more bulky.
Yes.
Did you routinely remove hardware with your previous non-custom plates?
So in Germany, all the plates need to be removed. Why? Because the patients think now they are healthy. Because of in Germany the insurance companies pays for it, everybody use it. But to be honest, with the new design, the thin plates, even if you leave it like normal plates, it's not a problem. Even the new plates now have the same amount of material what conventional plates are. So you can leave them in the patient if you want, but we in Germany, we are used to do the plate removal because of very simple, it's paid by the insurance companies, and we ask the patients if they want to keep it or not. And in Germany, the trend is like 95% they want to remove it because only then they think they are healed or treated.
Understood. And then a follow-up question to what you previously talked about with condylar positioning, Dr. Rana. How do you accurately assess condylar position during the surgery? And I believe you use
this is a very important question, and actually, I can only think on clinically evaluate the patient, and if I have a class 2, and then I try to measure him in a retrocondyle positioning. If I have him in a retrocondyle positioning, then in that positioning I use a preoperative splint. Doesn't matter if my engineer is doing that in a CAD/CAM procedure or my dental technician is using that. The same splint I use with the patient when I send him to the cone beam CT, because then is a condyle there. But in some cases, I want to move the condyle. Even in cases where I have some scoliosis or I want to bring in that in another position, or if the condyle is in a anterior positioning, then I want to move it. In that cases, I try to again clinically evaluate, like it is conventionally, where the habitual occlusion of the patient is, especially in class 3. And I always adjust it with a wax bite. And with a wax bite, if I have the patient there, I measure the condyle positioning with the cone beam CT. And that position, if I don't want to change it, I remain it with a Ramos fixation. And you could see the guide, what I have done at the Ramos fixation. I can show very fast there where it was. And this is the way where I want to keep this position exactly there where it should be. I think I have shown it would come fast to one of the, yes, now it will come. Exactly. Now you can see this is the fixation device. Now exactly it's adjusted to the maxilla. Now the condyle cannot move.
Wonderful. Well, I think we're out of time right now for questions for you, Dr. Rana. There are a few more, and I will encourage those participants to email Dr. Rana. Thank you all for participating in the scientific webinar offered today by the IAOMS. We're pleased to offer this benefit to all IAOMS members. Our next scientific meeting will be on Tuesday, December 12th on the topic of management of anterior skull-based tumors with Dr. Julio Cerro from Spain. So please watch for your email for more information about this upcoming event, and be sure to tune in. And again, I want to thank our speaker, Dr. Rana, for spending time with us today, and also the participants from all around the world.
You're welcome.
Very good. So thank you to both of our speakers. And with that, we will conclude today's program. Please take a moment to fill out the evaluation in the links box on the left side of your screen. Your feedback is very important to us. This session has been recorded and will be available within 7 business days. You may access the recorded archive on the IAOMS website. On behalf of the International Association of Oral and Maxillofacial Surgeons, thank you again to our speakers and, of course, to all of today's participants. Have a great day, and you may now disconnect.